My name's Jamie. I'm in charge of speaker ops here. If you've been here before, you probably have seen me. A couple of announcements. If you are a speaker, I lied to you and told you to get your badge at merch. Don't do that. Go back to where you registered as a speaker. I apologize, but your badge is there. Okay, that was the only lie I told you today that you know of. Secondly, Thor Collective is going to be starting a podcast out in the hallway around 3 o'clock. So that hallway in between the two parts of CactusCon. But they say feel free to come by and say hi. They're just going to be doing a live podcast, and so that'll be pretty cool. And so then the thing that you are all in this room for here today is our keynote. So frequently when I have one of those days where I'm like, computers are the worst, I remind myself, at least I'm not in medicine. Well, our keynote made the life choice to do both of those things. So yeah, ER doctor and hacker, Dr. Christian Demeff. So he is, like I said, an ER doctor. He is at UCSD as well. He was hired as the nation's first medical director of cybersecurity, which I think we can all agree is sorely needed. He's published on post-cardiac arrest care, CPR. I've asked him CPR questions, checks out. Health wearables and electronic health records. But what brings him here today is that intersection. So as much as I like to say ugh, computers, at least they're not people, there is an intersection between those two things. You know, we depend on cybersecurity for our health, and that's one thing that he's going to be addressing today. He's talked at DEF CON, RSA, Black Hat, B-Sides, and after this hour, CactusCon, on topics like hacking 911 systems, and is one of the co-founders of the CyberMed Summit, a multidisciplinary conference that talks about medical device and infrastructure security. Christian and his family own a husky named Tycho. I saw photos. He's very cute. And his talk today is titled Death by Malware. Dr. Demeff, thank you so much.
Thank you very much. All right. You guys can hear me okay? All right, so I want to say thanks so much. This is really awesome. We'll talk about it, but I'm from Arizona, so this is near and dear to my heart coming to CactusCon and being invited here to speak to you today. It means a lot to me. I'm gonna actually start off here why is this slide up here at the beginning? Did anyone read the video that was going on before? Raise your hand, yeah, if you were reading some of the slides of the videos and stuff. Those are all real Reddit posts that we pulled off of Reddit. Were involving healthcare ransomware attacks. Every single one of those was real. Really, really happy stuff, isn't it? That was really good. Really warms your heart. But all that was done by one of my grad students so young. So I really do have to give props to her for that work. And we'll be having a paper coming out about that where she took 5 years of Reddit data, looked at every single healthcare ransomware attack and quantified what happened to patients. And she trolled 5 years of Reddit data. Every sub, every comment on Reddit. So excited to show you guys that paper when it comes out. All right, I like unofficial polls when I speak, so I'm gonna start off impromptu. Raise your hand if you think someone has died from ransomware attack in the last 5 years. Keep your hands up, 5 years. 1 year, 2 weeks, 24 hours. You guys are pessimists. Are you guys okay? Are you guys okay? All right, you know, it's funny. So a lot of people outside this room do not believe the same as you, and I have a hypothesis. I have some data to show you. I think you guys are right. I do have a trigger warning. I know we're at capacity here. I know some people wish people would give us some seats and stuff, and this might happen. I have to be explicitly clear on 2 points. There are some videos of simulated CPR, not real CPR, no blood, no guts, but there's anatomy, not real anatomy, but animated anatomy videos of doing CPR. If that freaks you out, you should leave. Second thing is I'm going to show you a very sad audio recording, a real 911 audio recording. It is incredibly distressing. It is very triggering for folks in the healthcare. So I just want to warn you guys. I will also give another trigger warning right before I go, give you another opportunity to leave if you want. And that that audio segment is going to last about 2 minutes. All right? I'm Quaddi. That's what people at HackerCons know me by. They don't know me by the other stuff, but I am an emergency medicine doctor. We're going to talk a little bit about that. I know, a keynote talking about themselves, the worst, but I'm going to talk a little bit about that because hopefully that'll help. I'm an associate professor. I just made tenure. Oh my gosh, they made that mistake. Now they can't fire me. It's their fault. They didn't look into my file hard enough, I guess. I'm an associate professor of emergency medicine, biomedical informatics, and computer science at the University of California, San Diego, where I co-direct the Center for Healthcare Cybersecurity. All right, some questions. So Keynote without deep thought questions like that? Is that even a keynote? What is the human cost of ransomware? What is it? How would you even go about trying to quantify that? How would you measure what cost means? Is it lives? Is it pain? Is it jobs? Is it privacy? Is it data? Is it all the above? How would you go about even trying to figure that out? But the question that you guys raised your hands for earlier conveys to me that you think that cost is probably pretty high. Does security even matter? Like, we do this all the time. We talk about securing systems. We talk about dumpster fires and how it's the same thing over and over again. Unpatched Win 7, Forever Days, these things that really plague us as a field, as hackers and as InfoSec professionals. Like, it kind of feels some days like, this stuff even matter? Is what I hack even making a difference? Well, we're going to go back, how old am I now? It's 20 plus years ago. I'm in high school. I think that this video sums up what I was thinking about doing with the rest of my life when I was in high school.
Future. You mean a career? I don't know. I've thought about this quite a bit, sir, and I would have to say, considering what's waiting out there for me, I don't want to sell anything, buy anything, or process anything as a career. I don't want to sell anything bought or processed, or buy anything sold or processed, or process anything sold, bought, or processed, or repair anything sold, bought, or processed. You know, as a career, I don't want to do that. So my father's in the Army. He wants me to join, but I can't work for that corporation.
It's like exactly what I was thinking about in high school, right? All right. My early teens, I grew up a hacker, right? I have congenital club feet. I was born with my feet like, instead of like this, they were born like this. I had multiple surgeries. They had to basically fuse my ankles. It means a couple things. Number one, I'm not a very athletic guy. I wasn't hanging out with the cool folks at the football games. I just hung out with the cool people on the internet. And we didn't talk about things by our real names. We talked about things with our handles. And I spent a lot of time on IRC. And when you're there and you're a teenager and you're looking to, I don't know, like lash out rebelliously and you're not drinking alcohol or smoking, right? You can do things on the internet, the early internet in particular, that are really cool and fun. And so the hacker world just like drew me in. I learned how to hack, how to program, how to run networks and all these things. But all this time, this video of like, what are you going to do with your life is kind of plaguing me in the back of my mind. Decided to go to college. I didn't know what to study, so I studied philosophy so I could think really hard about never having a job. And I made ends meet by doing networks. So I built networks and I did sysadmin work and things for like basically a bunch of mortgage banking companies right before the 2008 collapse. So let's just say that didn't turn out very well for my business because all my clients should have gone to jail. But in any case, that's what I did. I would like build networks and I was hacking. I was going to DEF CON every year. I was really having a blast. But I really, really wanted to drive an ambulance. Isn't that a cool job? Not for folks who actually do it. If you ask anyone who does it, it is not a fun job. EMS is very, very hard for other reasons. But from the outside, driving an ambulance looks real sweet. So one summer I enrolled in a community college. And I took my EMT course and I got my certification and I showed up to the fire department. And I said, great, I got my EMT now. Will you hire me to drive your ambulance? And they said, sir, this is a Wendy's. We're a fire department-based EMS agency. You have to join the fire department. And I said, oh, how long is that going to take? Like a week? And they said, sir, this is a Wendy's. It's going to take you years to become a firefighter. Plus, you got those messed up feet. You're not going to fly. So tell you what, you can still get a job. It's at a hospital. You can take your EMT cert and go become an EMT in the hospital as a technician. This is St. Joseph's Hospital. It is 2 hours south from here. It was my very first healthcare job. I showed up, bright-eyed, bushy-tailed, in my scrubs I just bought, thinking I was going to change the world. And then I got pooped on. Repeatedly. I did a lot of really cool things, I will say, and a lot of interesting things. But I'll tell you, the thing that sticks in my mind is the very first time I ever saw a cardiac arrest. I'm starting off this talk light. It's about to get pretty heavy. If raise your hand, you ever seen a cardiac arrest? You ever done CPR on someone? Okay. A orchestra of chaos, finely tuned alignment with team members that know their specific job, coming together in concert to try to save someone's life. It's wild. It's bloody. It's loud. And I'm watching it for the first time as a person who has a front row seat there doing CPR on someone. And I will say some people would have seen that chaos of trying to bring someone back to life and said, that's it for me, I'm out. But for whatever reason, I'm wired a little different, and I said, this is the only thing I want to do with the rest of my life. So then I was like, I got to go back to med school. So I went back, took my prereqs, and I went to med school. In med school, you have to do research to graduate. I never thought I'd do research. But turns out I was really interested in doing CPR research. I wanted to understand the science of bringing people back and how we could do it better. And this is a pretty big scientific field. What if you do chest compressions at 100 a minute versus 120 a minute? What's the chance they're going to come back? What happens if you shock them at 60 joules instead of 200 joules? What's the odds it's going to bring their heart back? These are things that you can actually experimentally test, and I loved it. Did a bunch of research as in medical school. These are a couple papers we did, but the biggest thing I did this was the big paper I published in med school, and it involved me listening to over 2,000 911 calls of cardiac arrest. So when you call 911 and someone's heart stopped and they're doing CPR, they record all those videos. They record all those audio. I listened to 2,000 of them, and I figured out a way to try to teach dispatchers on the phone, the 911, the people telling you the instructions, trying to get help to you, try to teach them how to recognize when someone's in cardiac arrest sooner, and then teach someone on the other side of the phone how to do CPR, even they might not have ever done it. It's a hard thing to do, to teach someone on the fly in the middle of emergency how to do CPR, but that was kind of the point of the work we were doing. Raise your hand if you've been CPR certified, you do CPR. Awesome. So this is not alien to you. This is the first of the videos. It just looks like this. It's an animated video, but
Delivered. As you begin compressions, you are creating an artificial pump and doing the work of the heart manually. With each good, effective compression, you are building up pressure in the system, which will move blood around the heart and up to the brain. It does take time to get the blood moving with CPR, so it is very important to push hard and push fast to build the pressure up, which keeps blood going to the brain. Pushing down at least 2 inches allows for the heart to be squeezed and blood to move out. Pushing at a rate of 100 to 120 compressions per minute is
all right. So if you hate this keynote, at least you learned how to do CPR. You push fast at 100 to 120 beats per minute, about 2 inches, and you let for full chest recoil, and you don't give up until someone comes and helps you out, all right? But now you kind of get a little bit of a sense of what that means, and you push on the heart, you push on the chest. It pushes blood through the body to bring that important oxygen to the brain. Because I will tell you, it is much easier to bring back someone's body and have it still work than to bring back their body with an intact brain. All right? And that's
delivered.
the point of this slide. Is within 1 minute of your heart stopping, the flow of oxygen nutrients to your brain stops, the clock starts ticking. Within 4 to 6 minutes, that's all we have before you have a good chance that your brain is not going to come back the same. At 6 to 10 minutes, a very high probability. And then after 10 to 15 minutes, almost guaranteed irrevocable harm to your brain. All right. I promise I'm a lot funner to hang out with in person than on this keynote, so. I came earlier today, and I was seating the front of the audience here with a request. And Larnie, can you stand up for us? You're wonderful, wonderful. I just met Larnie today. This is not a... Larnie's going to do us a favor, and then I'm going to need you guys all to do me a favor. Larnie's going to start a timer on her phone, and every 4 minutes, she's going to raise her hand when it's done, and then I want everyone else that looks at her raise her hand to raise her hand, and I want it to spread all the way to the back. All right? Then once it spreads to the back, you can put your hand down. She's going to start her timer again, and she's going to do that every 4 minutes until the end of my talk, okay? So raise your hand every time Larnie raises her hand, and then put it down. Why are we doing this? Because at 4 minutes, your brain starts to die. And I want you to think about how quick that is as I'm going through this keynote, all right? And it's going to be a reminder of how important this is through it, okay? All right, you can go ahead and start. This is the last trigger warning. So if, again, this is a very distressing audio recording of a 911 call, all right? Last call.
Okay, what's the problem there?
My husband, he's going through chemo. I don't know if he's breathing right now.
Okay,
He's
can you
not
look and see
breathing.
his chest is falling and rising?
It is a little bit, but he's turning blue.
Okay,
Matt.
what's your last name, ma'am?
Baker, Baker.
All right, and you're on cell phone 3.
Yes. Matt, come on, honey.
Okay.
Matt, look at
How old
me.
is he, ma'am?
Matt, he's 39.
39.
Oh, yes. Matt, honey, you got to wake up. Matt.
Can you get him on? Where is he right now?
To bed.
Okay, is there any way you can get him onto the floor on his back?
He's on his back on the bed. I'll try and get him up.
Okay, you there by yourself?
Yes. So my dad came over.
Okay, see if you can get him on the floor on his back and we'll start CPR.
Okay, come on. Come on, Matt.
Let's get him on the floor.
All right. Yeah, come on, Matt. Okay, Matt. Okay.
Ma'am, how we doing? Okay, ma'am, I've already dispatched you 3 units. I just want to try and get him on the floor so we can help him, okay?
He's on the floor.
Okay, what I want you to do is I want you to tilt his head back a little bit. Tilt it from the chin and put your hand on his forehead and tilt his head back.
Matt,
Can you do that?
Dad, let go. If they want me to do CPR, I'm going to do it. His chest.
That was 2 minutes out of 4.
Okay, what's the problem?
You're probably thinking this right now. All right. Larnie, you're up, right? You're close? All right. Takeaway 1. Modern medicine is critically dependent on connected technology. I'm going to make an argument at the end of this talk. You could put any other critical infrastructure into this point, and it really does mean lives, but we are critically dependent on connected technology. As an ER doc, I can't do anything effectively without microprocessors, software, firmware, code, connected networks. This is a trauma bay. This is a young doctor doing an ultrasound on a critically ill patient in the trauma bay, looking to see if they need to put something in this patient to save their life, and they're doing so using an ultrasound machine that is running Win 7. This young doctor here is entering data into electronic health records, entering in orders for life-saving medications, typing it into what I essentially call the the operating system of healthcare, which is electronic health record. Literally, to quantify this, one of my favorite, saddest studies, they did this over 10 years ago, so it's definitely worse now, I'll tell you. They followed ER doctors around for 8 hours and measured what they spent their time doing. In that 10-hour shift, they had over 4,000 mouse clicks. And the conclusion was that they spend significantly more time doing data entry into the electronic health record than any other thing in the emergency department as a doctor. 4 minutes. This has only gotten worse. In fact, even in taking care of a patient that's having a stroke, for instance, a life-threatening, time-sensitive medical condition, at every part of the patient's journey, from home to calling 911 to the ambulance coming, to arriving at the hospital, to getting checked in the electronic health record, to getting a scan in a CT scanner, to a doctor entering orders into a computer, to picking up medications out of a network-connected medication cabinet, to finally giving a life-saving medication to a patient having a stroke. Every single one of those points involves vulnerable code, involves really embarrassing availability attacks that are low level and easy. Like, we're talking any bit of this chain being broken and the patient getting care at the other side, maybe they don't live. Takeaway 2, cyber attacks on healthcare are increasing. Does anyone want to argue this with me? I once had someone say, no, they're not. I said, I don't think so. I try to quantify this with some data. We're trying to do an updated study on this to look at ransomware attacks and their frequency. Until we publish that, the only one I have peer reviewed is out of 2022, and it shows basically every year after year, ransomware attacks increasing to about 1 a week in this country and about 1 a day in the whole world. Hospitals getting hit with ransomware attacks. What are some of the examples we have from the United States about ransomware attacks in healthcare? And there are several I'm going to show you. One was a few years ago. It was called Ascension Health, all right? Oh, sorry, we're going to talk about Change first. Does anyone remember the Change healthcare ransomware attack? Raise your hand. Oh, yeah, sorry. You guys probably work in the field. Sorry. Those were dark times. If you're not familiar, there's this company called Change Healthcare. It turns out that they are responsible for sometimes 90+% of the digital plumbing between your hospitals and your insurance companies. And they got hit with ransomware. And it lasted about 4 to 6 weeks, depending on the mop-up. It cost this country, it's going to be approaching $4 billion. Hospitals are closing because of this. Clinics are closing because of this. And at the heart of it, it was because a single third-party vendor has far too much of control over digital health communications in this country, right? That a single point of failure resulted in not only patients not being able to get the care that they needed, but the medications that they so desperately needed. Because one of the critical functions of Change Healthcare was to prior auth drugs that you get prescribed. So people on oral chemotherapy drugs that need this to fight the cancer showed up at their pharmacy to pick up their medications, and the pharmacy said, we can't check how much this drug should cost you because the digital plumbing between our system and your hospital and the insurance company is not working right now. So if you want this drug, it's going to cost the out-of-pocket cost. It's going to cost $5,000 because we can't bill your insurance because this system's broken. When all is said and done, this is probably the largest and most expensive healthcare ransomware attack in the United States to date. I've been studying this field for about 15, 14 years now. It's definitely not going to be the last. The cascading failures of this single attack are going to be rippling for years to come. I mentioned hospital closures, clinic closures, doctors going out of business, patients getting delayed care. It's pretty gnarly. Takeaway 3. 4 minutes. That's how long it takes before the brain stops. Cyber attacks impact these technologies and cause patient harms. Another example of a ransomware attack hitting a hospital system specifically was Ascension. There were hundreds of Ascension hospitals. Because of a merger and acquisition that had happened previously, they were in the process of merging 2 hospital IT stacks together, and one of those systems got hit with ransomware, and it spread to dozens of hospitals in a matter of hours. This wasn't just in one small area, one small town, one city. This spread across the entire country. My kids are in the audience, so kids, close your eyes. These are screen caps from Twitter, X, whatever they call it now. Real doctors and nurses talking about some of the stuff that was happening during Ascension. There are literally hundreds of things like this. All right, kids, you can open your eyes. This one's interesting to me. Every Ascension hospital is essentially down. We brought a trauma. There's a patient that's like a car accident or a stabbing or something like that. We brought them to an Ascension hospital, and the trauma team was freaking out because half the team didn't get the page that this critically ill patient was coming. They're charting on paper records in the intensive care unit. Everything is completely down. So everyone remember CrowdStrike? Oh, yeah. We'll talk more about that. Not a ransomware attack, but here's some coverage discussing how it took out hospitals. It took down 911 dispatch centers. We're going to talk more about that too, the CrowdStrike outage. I kid you not, I pulled this off of Reddit. Some doctor or nurse in a hospital during a ransomware attack drew this on the whiteboard. The Grim Reaper themselves. Did someone say downtime? What's cropped out of this picture is you can see a star on the top that says admitted and what ends up being a grid. That's how they're tracking patients in a hospital. They're writing them on a whiteboard because the systems they usually use to track patients in electronic health record weren't even functioning. They can't page doctors that they need to come in quickly to take care. They can't execute surgeries quickly in the operating room. They can't give medicines quickly. They can't do all these things. Cyber attacks degrade, delay, disrupt, and decay the digital systems that power timely, life-saving medical care. That's a nice story. And it's one I don't think I'm going to have too much problem convincing you guys in the room is reality. But policymakers in Washington, pharmaceutical companies, insurance companies, hospitals, sometimes they need data. And sometimes even when you have the data, it still doesn't change their mind. But the first part is to actually get the data. So you're probably wondering, this is easy, right? We just go like find some data that shows that ransomware attacks are killing people. We'll go show up and we'll ask some policymakers to make some laws to say, hey, we should probably care more about this and give some resources to this and shore this up, and it'll all be fixed. No, it's not the case. It's really hard to get ransomware data in hospitals. And the first three reasons, are there any lawyers in the room? Not that you raise your hand after I ask that question, right? All right, I know you're out there. We do like you and we need you. But I think the first three reasons why there is no data about this, so there's very little data about this, is because lawyers, when a hospital gets hit with ransomware, they don't talk. They tell their employees, don't talk about this. They are very adverse to sharing this because they have tremendous liability. That's in 4 minutes. There's other reasons why it's very hard. One, how do you know if you're taking great care of a patient? One of the ways that we do that is by looking in the electronic health record. This is a very complicated monolithic software that the hospital uses to do all sorts of stuff. But one of the things it uses is it's to record timestamps when things happen. I see a patient, they're having a stroke. I go into electronic health record. I put in, I need a CT scan. I put that in the electronic health record. It's timestamping and logging all of these things. So I can go back later and say, why did it take 6 hours to order a CT scan that should have been ordered in 3 minutes, right? That's one of the ways that we can actually measure how well we do things is by recording them. That is gone during a ransomware attack. So our logs essentially are gone. Our quality metrics go out the window. Everything takes longer. It's also very incredibly chaotic. All right, but we did the next best thing. We published this paper a few years ago, and it tried to do the second best thing. If I can't get data at a hospital, the second best thing is I can get data at hospitals around ransomed hospitals. And in 2020, 5 hospitals in San Diego got ransomed by Conti. This was a single healthcare system. It got ransomed. They were down for a month. I just so happened to work at hospitals literally across the street from these ransomed hospitals. And I walked in, ransomware attack happened late on a Saturday. I walked in on Sunday morning for my Sunday morning shift, and I saw a very bizarre sight. The waiting room was overflowing at 10 o'clock in the morning on a Sunday. That does not happen very often. I walked in, I said, what is going on? I looked towards the ambulance bay, and there are there are like 7 ambulances waiting to offload their patients. I never see that. what is going on? Go to the charge nurse. And they said, didn't you hear? There's a cyber attack across the street. And so we went back and we looked at what happened at our hospital before, during, and after the ransomware attack to try to understand how it impacts patients. Finding number one, I'm an ER doc, so I measured what happened in the emergency department. I'm not going to bore you with this table. I'm just going to tell you some of the highlights. Number one, we saw way more patients than we were used to. We were overflowing at the gills. We saw way more ambulances come to our system, which are, those are sick patients. In fact, at the height of the ransomware attack, we saw 3 times more ambulances in one day than we had ever seen before. Can you imagine just one day out of the blue, you see 3 times more ambulances than you did the day before? That is incredibly taxing. More patients left without getting care. If you were waiting in the emergency department, you waited 40% longer just because there was a ransomware attack in your town. Not even at the hospital that you're getting care, but just in the town that you're at. This is a graph showing hospital diversion hours. So long story short, a hospital gets hit with a ransomware or they have a tornado or a big flood, they can go on diversion. They can say, hey, stop sending ambulances to us. We are overwhelmed. That's called diversion. This is measuring in San Diego County all of the hours that hospitals went on diversion. You see that giant spike in the middle? On the left is before the attack, the month before. In the middle of this is during the attack, and after, it kind of goes back to normal a little bit. And during that month of the attack, on the 5th day, we clocked 190 hours where hospitals said, we can't take care of your patients. That's higher than any other time we recorded this data in San Diego history. And then I take care of strokes, gunshot wounds, severe sepsis, toenails, hunger, homelessness, or I take care of everything in the emergency department. But one of the things I'm really worried about is these medical conditions that matter when minutes matter. Heart attacks, strokes, traumas, sepsis, those types of things. And we took one population of stroke patients and we said, hey, what happened in that? We saw far more stroke codes. We had far more confirmed strokes, but luckily, even though we were overwhelmed, we were still able to give quick quality care to these patients. But if you ask those stroke doctors during that month, they often report that as being like the worst month of their life. Because they were basically running back and forth from stroke after stroke after stroke because 3 out of those 5 hospitals that got ransomed were stroke centers. And they couldn't take care of strokes, so they all had to come to us. What is this? This is getting at this kind of, we're all in the same cyber boat. And you could enter, it doesn't even have to be healthcare. It can be so many other different fields. It doesn't have to be critical infrastructure. The thoughts that you can build your walls high enough where your vulnerabilities are all that matters and you can withstand the storm and have no impact or interdependencies is not correct. What happens to your neighbor will impact you. And this kind of ecosystem effect is what we captured in this paper. But now we're going to come a little bit full circle. I told you I grew up in medicine studying CPR, and I really wanted to know what happened to those patients that had cardiac arrest during that ransomware attack. So a year later, we published this paper, and it did the same exact attack, that 5-hospital Conti attack, and it looked at patients that were unlucky enough to have cardiac arrest, to have their heart stop, and we wanted to measure what happened to them. There's a lot of acronyms and stuff. You don't need to know much of it. All I want you to look at is the following statement. If you were unlucky enough to have a cardiac arrest in San Diego during the ransomware attack and you were treated at my hospital, if you had done that a month before the attack, your survival rate with a good brain was about 40%. 40% of the time, we could get your heart started back up, and we could do so in an amount of time where your brain was still functioning. You could probably still take care of yourself after your cardiac arrest. It was 4.5% during the month of the ransomware attack. You almost had a 10-fold decrease in your chance to walk outside of a hospital after a heart attack, not a heart attack, cardiac arrest, just because there was a ransomware attack in your town. Takeaway 4, hospitals are closing or consolidating And what we're doing is just building larger and larger risk pools for catastrophic failure. Now, this is a trend that is not new. This has been coming on for some time. We could talk at length about why this is happening in healthcare in the United States, but that's a truly depressing conversation. Instead, what you need to know is that rural hospitals are at increasing risk. They cannot pay their bills. They do not have the population to help support them, but they're so critical because if you live in rural America, that hospital next to you might be the only hospital within 800 miles. And if you have a heart attack or a stroke or you get in a car accident, thank you. And that hospital that was in your local town would have been the one to take care of you, but it closes, you might be out of luck. Mergers and consolidations, this catastrophic failure risk is a big deal, but it also is compounded by the fact that when a hospital system buys another hospital system, they do not keep two disparate systems. They, for economies of scale and efficiency purposes, they want to put everything under one tech stack, one electronic health record, one email system. That's why with Ascension Healthcare, we had hundreds of hospitals potentially be impacted by a ransomware attack, wherein one back in the day wouldn't have spread to so many. 4 minutes. We talked about CrowdStrike. Now, this is not a ransomware attack, and I'm going to be very clear. What I'm about to talk about are associations. You can tell I've been talking to a lot of lawyers. I don't like doing that. But this is some coverage of a paper we published a year and some change ago, a year ago, that looked at the CrowdStrike outage and looked at what hospitals went down the same day. And you can draw your own conclusions on whether or not you think that was related or not. Sometimes the call is coming from inside the house, right? Sometimes the tools and technologies we use, they don't get ransomed, but they break. And when they're critical parts of our digital infrastructure, and they tend to be supporting huge amounts of critical systems, when they fail, we have similar failures to what we see in a ransomware attack. But what did this outage do to healthcare? Well, our research group had been monitoring all the hospitals in this country on about an hourly basis for about a year and a half. We had been measuring every hour we were going and checking in on these systems. Are you up? Are you down? We checked over a bunch of protocols, not just port scanning stuff, but a lot of other really cool stuff. And we saw this huge outage occur. We were able to measure how long these hospitals went down. And then we went back and looked at the specific things that went down, and we tried to figure out what they were. And in about 22% of the time, what went down were critical systems, patient-facing systems, things like patient portals, 911 dispatch centers, telemedicine platforms, secure document transfers, these types of things we saw go down about 22% of the time. About 15% of the time, we saw operationally relevant things go down for hospitals, things like staff scheduling, phone systems, portals for ticketing, like your ServiceNow we'd see go down a lot, these types of things. We saw a whole bunch of stuff, about 5% of it, not a whole bunch. We saw a bunch of research go down. We saw trials for cancer care, et cetera, go down because of this. Now, it comes back quickly as they recovered from the outage. This is the type of stuff that we saw as a natural experiment. What depends on this stuff? And when it fails, what goes down? And how important is that? In my opinion, I don't think anyone has even a beginning grasp of just how dependent and interconnected we truly are. And we haven't yet to begin to understand where these cascading failures will lead us. All right, takeaway number 5. We're almost done here. This problem is really hard to fix quickly. We're going to come back a little bit to our CPR discussion, okay? You know, cardiac arrest is usually due to heart disease. Heart disease has risk factors. If you smoke, drink alcohol, you're super stressed out, It's no one here in this community, I'm sure. That's just like DEF CON in a, isn't this just DEF CON in a single slide? Is your risk factor that you go to DEF CON? Yeah. You probably have coronary artery disease. I'm going to DEF CON for 20-something years. I'm in there too. But these are things that give you risk factors. If you have these, you're more likely to have something. Do they say you're guaranteed to have it? No, but they change your probability. What are the risk factors for healthcare cyber? Why are we in such dire straits? Well, generally speaking, we could talk about why healthcare costs so much. Again, another very depressing topic, but for whatever reason, even though it does cost so much, most hospitals in this country barely break even. Many hospitals make no money and they bleed red every single year. Okay, so they have little financial resources. Has anyone here worked in healthcare for cyber? Raise your hand. Yeah, keep your hand up if you enjoyed that. Yeah. Oh, okay. There's a couple. You guys and gals are amazing. It's a truly because it is a very challenging environment to work in. But generally speaking, hospitals can't afford the talent that they need to defend the enterprises that they are in charge of. They have tons of legacy systems, period, because they're also incredibly expensive to replace. An infusion pump can cost $10,000, $15,000 to replace, and they need 1,000 of them over their enterprise. It's not something they're going to turn over like a laptop every 3 to 5 years, right? So what does that mean? It means that they're still running Win 7. The consolidation third-party risk we discussed. There's all sorts of crazy stuff with geopolitics, international law that make this really hard, etc. These are the risk factors. Just like these risk factors for heart disease, these are the risk factors for why healthcare cyber is in no good shape. So the question I have to many folks that just care about healthcare cyber, which you guys don't, you guys care about lots of different things, it's like we have been trying for many years to do this, build this wall higher, install the latest tool, have a really awesome SOC, right? Meet this compliance framework, get this certification, et cetera, because these are all efforts to try to prevent an attack like ransomware, and that's incredibly important. But that's changing risk factors. It's like trying to get people to stop smoking, to not be old, and to quit drinking. Is that usually very effective? No, that's hard. Just like it's hard to build our walls higher, to employ the latest tools and do all that stuff. Does it mean we don't do that? No, we still continue doing that. But in healthcare cyber, at least, we don't have a CPR for hospital systems. Like we don't have a try to bring a system back once it fails. We don't fail gracefully and we don't recover quickly. What's the CPR equivalent for a hospital in a ransomware attack type of thing? And so we mulled around this. We've been struggling with this for years, and we launched the center a few years ago, and we were so lucky in many different ways, and privileged, and lucky. We were one of the first awardees at the center for essentially the ARPA-H is a new government agency. It's kind of like DARPA. And the idea is to do crazy healthcare stuff, like let's engineer microbots that can clear out your coronary arteries, or like let's figure out cancer vaccines. The idea is to go crazy and to do crazy moonshot ideas in healthcare to try to save people's lives. Well, they dumped some money into healthcare cyber to try to fix this problem, and we were awarded one of their very first awards, which is really awesome. I have a team of 22 folks, so I don't do anything. The grad students and the professors, and they're the heroes. Like they do all the work. I just get to talk about it. And if they were here right now, I would just give them the personal thanks from the bottom of my heart. But what did they do? They asked this question: what if we could rapidly restore essential connected clinical workflows, maintain patient safety features right after a hospital's been ransomed? And that's what we spent the last 2 years building. So I'm kind of amped to show you guys a little bit and talk about it a little bit more on this talk. I only got about 5 more minutes left. But we built a prototype system. It can support a 20-bed emergency department. It has private 5G cellular. Thank you. It's got its own I'm not saying air gapped. I would never. Never. I would never say such a thing. It's got some security considerations and things. The idea is you could roll this into a hostile network and take care of a patient. Take care of patients in a 20-bed emergency department. That's what we're currently scoped for. This thing fits in the back of this. If you can't see, I'm in the driver's seat there at a hospital in the middle of the Imperial Desert. It's like halfway, not a little bit. It's like a third of the way from San Diego to here. So we deployed this in El Centro, and from the time, it's a hospital. The system fits in the back of this U-Haul van, and we deployed it in the hospital. It's got the phone systems. We have our private little phone system. We don't use Wi-Fi. We use private 5G. We have all the laptops, the phone systems. We bring all that type of stuff because you can't rely on any of the infrastructure. You don't know what's infected. You don't know. You don't want it to jump. There's a bunch of reasons. So we had to bring everything ourselves and rapidly deploy it. It's been fun. We've learned a ton. And from the time we open the back of our van to the time it gets deployed in the emergency department, we clocked it at 34 minutes. So the idea is you get hit with ransomware, you roll the sucker out, and so this is all academic research. This is like, can we show that it's possible? For many years, we just said, we're going to deal with the downtime. We're going to do the forensics. That's why healthcare ransomware attacks last weeks and not months. That's why we're going down to paper downtime. But the idea is, can you bring something to help them at least take care of patients in a more safe manner using stuff like this? Because that's what they're used to. Some of the comments you saw from Reddit, from other folks, is that modern doctors and nurses, we don't know how to do things on paper. I'm of the generation of docs, I've never used paper records. I've only used the electronic health record. I have handwritten prescriptions maybe 5 times in my entire career. If you ask a new nurse or intern doctor coming out of training right now to do anything on paper, they're going to laugh at you. And then you take all that stuff away from them, and you never train them how to actually take care of patients without it. It's a recipe for people to die. So let's take it a little bit out of healthcare, because now you guys are like, I'm never going to a hospital. Like, just let me die. It's worse to go there. I want you to take what I just did, which was depressing 45 minutes of content. At least I taught you CPR. And I want you to think about the failures of healthcare cyber and where you are and what you do and what you work on and what you hack on and what you defend. And I want you to think about if you're making similar mistakes, if you have similar risk factors, if there's something that you can do in your sphere to make it stronger, more resilient, fail gracefully, or recover quicker, or all the above. I want to plead to you as well that you may think that what you do is not important. Or you may think, I work on some system, it's not electronic health record, it's not a CT scanner, whatever. Guess what? You have no idea the code that people write that makes it into healthcare or makes it into insert any other critical infrastructure field. You have no idea the code that you write might end up supporting a patient's life and you'd never know. So that's a responsibility that you have to take upon yourself to think about that. And don't just say, I'm glad I don't work in healthcare. Because you probably do and you don't even know. Are we prepared for weeks or more of downtime across a whole society? Water, power, medical? No. Are we only becoming more dependent? And is this ability for us to be resilient just slipping away and it's not going to ever be possible? And is that a world that we want to live in? Is that a world that as hackers, we want to have helped make? No. In fact, I argue we're the only ones right now probably fighting against it. What interdependencies between the digital and physical worlds exist? How do we ever understand the complexity and prepare for failure? These are things that keep me up at night. What you do matters. What you hack can change the world and you have no idea, and you might not ever understand or ever be told or ever become relevant to you because it's just so far removed. But that is what modern technology is like. No one else is going to do that. And so as a plea in the end of my keynote here, and I'm sorry, it's been depressing, you have to think about these things because no one else is going to. Everyone else is going to tell you it's not going to happen. The systems are better than that. And you're the ones that have showed them, no, that's not true. Look at this. And if you don't act as a counterbalance to that, the world will get away from us and there will be no coming back. You guys are the voice of reasons in the room. And I appreciate you folks. And with that, I want to say thanks.